Good afternoon to everyone joining us today. Welcome to the Alzheimer's Association's Lunch and Learn call-in session, Home Care, What You Need to Know. Today's topic is important for all families affected by Alzheimer's disease. I would like to acknowledge that June is Alzheimer's and Brain Awareness Month. Pledge to Go Purple and visit alz.org/Go Purple to take the pledge and join the international conversation about Alzheimer's disease. You can learn about other educational programs offered by the Association at www.alz.org or by calling our 24/7 helpline at 1-800-272-3900. It is a pleasure to introduce today's speaker. Brian Andrew Tully is a founding partner of Tully & Winkleman, P.C. He is certified as an elder law attorney by the National Elder Law Foundation and has been striving to help seniors since 1998. His professional mission is to help seniors and their families find peace of mind. The law practice focuses on life care planning, which helps people find and pay for good long-term care by bundling asset protection, public benefit qualification, care coordination, nursing home advocacy, and crisis intervention. He is a member of a number of professional affiliations and is a member of the Long Island Chapter's Board of Directors. Let's welcome Brian Tully.
Thank you, Kate, and thank you to Steve as well. It's a pleasure to be here, an honor to talk to you folks. As was discussed, my topic is home care, and yes, these are things that you need to know. So let me get started. There will be certain times when questions can be answered. I'm fine with that, and then at the end, we can open up for questions as well. In discussing home care, to us and to those that have been through this, we're talking about Medicaid primarily. Home care is often a time when your loved one, parent, spouse, sibling, neighbor, needs some type of care within the home or within the community. It often refers to any type of care that's not in a nursing home. So home care can refer to, again, care within your home, within the parent's home, can refer to a child's home or even assisted living or independent living, an apartment or co-op, etc. It's within a residence. So home care itself often takes different stages and transitions. In our practice, we use something called an elder care continuum to help people see the progression. Simply, there's a time, as we know, when there are no functional or limitations that a person is, capacity limitations that a person suffers from. Then there may be an increase in a functional limitation, and that may progress. So initially, there's a time when no care or help is needed. That's really the initial phase. Then we have a time perhaps when there is a level of informal care that's needed. Informal care would be a child helping out or a spouse doing what they can to help around the house and to assist with what we call the activities of daily living. That informal care can go weeks, months, years. It can include running errands, helping with bathing or cooking, helping with eating, reminding for medication times and which medications to take, or even just sitting there and being a comfortable presence with the person. But again, that's informal and there's very low cost associated with it. That can progress into what would be more of a part-time type of setting of more formal care. And that more formal part-time care would be paid for. That can be somebody from a local community organization, such as a church or a synagogue or a senior center. And it's generally a couple hours a day. Sometimes families pay off the books for somebody. Sometimes it's a volunteer from one of those organizations. But it's one where the care is provided, the help is provided from somebody outside of the family. That can progress into a full-time level of care, which is oftentimes when somebody has to start considering the costs because it may become cost prohibitive at that point. Home care can range anywhere from a couple $100s a month, depending on what kind of care and hours you're receiving, up to about $8,000 or $9,000 a month for somebody to live in 24/7. So when you have that type of cost, you have to consider how it's going to be paid. Some families and individuals have something called long-term care insurance. So they use that long-term care insurance benefit to pay for care around the house. And when I say care around the house, I alluded to it earlier. It's what's called activities of daily living. When we need care, there are different types of care, and there are different payors for different types of care. So if somebody, for example, needs a medical or has a medical need, they're going to see a doctor or a hospital or an emergency room. That type of care is paid for by Medicare itself. That's the health insurance. So Medicare pays for medical needs, which again can range from doctors, hospitals, emergency rooms, physical therapy in a skilled nursing facility, for example. But then there's the whole other side of care, which is what we're most faced with in these types of situations, which is a level of custodial care. And custodial care is not medical by definition. Custodial care is help with what we call the activities of daily living, such as walking, bathing, toileting, dressing, transferring up and out of a chair or a bed. Everything that we take for granted and everything we do in the morning just as we get out of bed, those are your activities of daily living. That type of care, again, is not medical, it's custodial, and Medicare doesn't pay for that. There often is a small period of time after discharge from a rehabilitation facility when Medicare will be involved, but that's very limited, and that's something that cannot be relied upon. So when it comes to more of a consistent need for this custodial care help, there are different payors of that type of care. As I mentioned, long-term care insurance is something that you can go on claim for that if you already have that type of a policy. Somebody else might use cash, but as I mentioned, the costs can be exorbitant, so that is not something people prefer to do. Lastly, they look to the Medicaid program to pay for that type of care. Medicaid has two programs in this realm of elder care. The first one is home care, and the other one is institutional care, or long-term care, or chronic care they call it, which is care in a nursing home. But we're focusing today on this home care program. Home care covers personal care services, can cover nursing, cover physical therapy or occupational therapy, but primarily it's for home health aid services. And pursuant to what's called the New York State Medicaid Redesign Initiative, managed long-term care has become mandatory. Managed long-term care, or what we call MLTC, is now kind of the law of the land when you're dealing with community Medicaid. All right, community Medicaid is this home care service program. Now, this MLTC program has become mandatory for most Medicaid recipients, and it's those that are over 21, are eligible for Medicare and Medicaid, and of course are in need of this community-based service for more than 120 days. So there has to be that time frame where it's expected to last. The need will be there for at least 120 days. The Medicaid recipient must enroll in an HMO, which again is this MLTC company. And that MLTC company, not the Department of Social Services, which is what it used to be last year and prior, that MLTC company is responsible for determining the eligibility for care, assessing the amount of care that's needed, contracting with providers, the actual companies and the aides, and paying the providers as well. Members of those MLTC organizations can only receive covered services from providers in the MLTC plan, and the plan is paid the same amount for each member by Medicaid. It's what's called a capitated system. So regardless of the level of care that the recipient member needs, that MLTC company is only receiving X every month. So unfortunately, as with all health insurance, it seems, there's an incentive for them to minimize costly services. In addition, we have to talk about something called FIDA. FIDA has rolled out for half of Long Island recently, and FIDA is a program that stands for a fully integrated dual advantage plan. Again, FIDA, F-I-D-A, fully integrated dual advantage plan. It has rolled out for New York City and Nassau County, but the state put the brakes on for Suffolk County and Westchester. It was supposed to be out, I believe, February 1st, and then they postponed it to March 1st, and now it's postponed indefinitely for Suffolk. So if you're in Nassau, you would have received correspondence if you have a loved one on community-based Medicaid about this FIDA program. What FIDA does is it combines under one managed care plan a full Medicare Advantage plan, which is a private Medicare plan, a Part D prescription drug plan, and this managed long-term care Medicaid program. So it combines under one umbrella, one managed plan, all of the services, Medicare and Medicaid and drug coverage that a participant recipient would need. As of now, the MLTC plans for community Medicaid provide Medicaid home care, dental care, eyeglasses and optometry, transportation to the doctor, medical supplies, hearing aids and audiology, as well as other services. But MLTC plans as of now, in Suffolk, but they do in Nassau, don't provide for the regular primary medical care. But through FIDA, New York City and Nassau, if you have a FIDA plan, your Medicare and Medicaid are all combined now through this FIDA plan. In Suffolk, you're still separate. You have your Medicaid services and your Medicare services. As this was rolling out, these FIDA plans were rolling out, we were recommending people to not enroll. You have an option to what's called opt-out. And if you find that your loved one has actually been opted in because FIDA had what's called a passive enrollment. So if you find that your loved one who's on Medicaid is now a part of FIDA, please consider that seriously and determine whether or not you want to remain in that program, because you can always opt out and go back to the separate Medicare and Medicaid and use whichever physicians you were using. Okay, so that's something important to consider. Now, the Medicaid program itself in New York is really a fantastic program. The community Medicaid program it offers services and has the help and the programs really better than other states. So it's something to take advantage of if you're able to. So what I'm going to now spend the next 10, 15 minutes or so speaking about are different aspects of Medicaid eligibility. Okay, but before I get to that, does anybody have any questions at this point? Steve or Kate?
As a reminder, if you'd like to ask a question, please press star 1 on your telephone keypad. Again, star 1 if there are any questions. I have no questions on the line.
Great. Thank you, Steve. So the different aspects of community MLTC that I'm going to talk about, I'll list them first so you can kind of get a picture of what we'll get into. We're going to talk about assets with eligibility. We're going to talk about the income concerns. Number 3, we're going to talk about penalties. Number 4, we'll talk about a look-back period. Number 5, we'll talk about documentation. Number 6, we'll talk about the assessments, the health assessments. And finally, we'll talk a little bit about the risks of Medicaid. And when we meet with folks, we lay this out for them, whether we're talking community Medicaid or the nursing home Medicaid. So we use the same kind of table to explain these different eligibility factors. Now, in the community Medicaid world, there is an asset maximum that an applicant is allowed to have in their name, and that maximum is $14,850. So $14,850 is the most that can be in a person's bank account, or can be in an investment account. It's any type of asset that the applicant has. That 14 number is the maximum. It's always smart to, when applying for Medicaid, to have less than the maximum because there's no reason to be that close to it. In addition, you want that bank account that they have, which is typically the best way to go, to be a joint account with somebody else. God forbid the applicant passes away. That way, that bank account doesn't fall into their estate, which, as I'll talk about in risks, is then subject to recovery by Medicaid. So you generally have one bank account, less than $14,000. In addition, there are some exempt assets that a person can have. The home is exempt from Medicaid eligibility. So where the person is living is exempt. The Medicaid program will not count the home against them as an asset for the application. However, when it comes to eligibility planning for Medicaid, we often transfer the home out, typically to a spouse, so that it is not in the applicant's name when they're on Medicaid and when they pass away. So again, they can have the home, but we don't like to have it in the applicant's name. Excuse me. In addition to the bank account less than 14, the Medicaid applicant can have an IRA or 401k. Those assets and those accounts are exempt from Medicaid eligibility, provided two things are happening. They are taking their periodic payments, which means they are over 70 and a half, which means they're taking their required minimum distributions. Okay. It also means that income is subject to the Medicaid eligibility guidelines. And in this world of community Medicaid, the income from a retirement account, where the account itself is protected and not touched by Medicaid, and the income is included in the calculations, sometimes Medicaid requires that minimum required distribution that's received annually to be increased to a maximum number. That's generally, there's a whole other table that comes into play to determine the actual monthly payment or annual payment, but it's roughly 50 to 60% more each year. So that's the trade-off when we're talking about an IRA. Medicaid will allow the applicant to have the account, but the income and even a maximized income is susceptible. Okay? Now, the income itself, so I'll move on to the second section. When we're talking about community Medicaid, there is a maximum allowed of $845. $845 is the amount that an applicant can receive and do anything they want with. Now, there's a couple scenarios here. If they are married, then there's one scenario. If they're an individual, then it's another scenario. If they have less than $845, it's straightforward, whether they're married or single. If they have more than $845, and if they're married, then what you might be looking at is a transfer of any income over the $845 to the spouse not receiving Medicaid, up to a maximum allowance of $2,980. So if an applicant has, let's say, $2,000 themselves, and their spouse, who's alive and living with them, only has $1,000 income, the amount over the $845, which is, I guess, like $1,155, would be transferred to the spouse not receiving Medicaid, and they'd be allowed to keep the whole income because the spouse not receiving Medicaid is under the $2,980. However, in a circumstance where we have a Medicaid recipient greater than the $845, but they either aren't married or the spouse not receiving services is over the $2,980, then we have to utilize a different strategy. So if the Medicaid recipient, again, is over $845 in monthly income, and they either are an individual or their spouse is over the $2,980 limit for them, then we have to utilize a tool called a pooled supplemental needs trust. And a pooled supplemental needs trust is a trust that's already in existence, and there's about 20 of them in New York State. And they are a trust that exists, it's a nonprofit that actually runs the trust, that exists to protect the income overages, that amount over $845, for seniors that wish to receive Medicaid and stay in the community. Okay, so this pooled supplemental needs trust, also called a pooled trust or a pooled income trust, exists to shelter the income of the individual if it's over $845. Okay, they're used every day by hundreds of seniors, if not thousands of seniors. Now, what happens once the income gets paid into this pooled trust? Well, each month that the applicant is on Medicaid, they have to deposit their income overage to this pooled trust, and then you tell the pooled trust how to spend that money. Okay, so it can be spent on anything that is for the applicant's benefit, provided it's not medical in nature. Okay, so the pooled trust cannot pay for an insurance copayment, cannot pay for a doctor, cannot pay for an aid, but they could pay for anything else that has the applicant's name on it, such as a credit card bill, utilities for the home, real estate taxes for the home. Okay, so it can be used to help keep the senior, the parent, in the community, and it's not lost. It's a great tool, and it's definitely worthwhile. The only alternative to not using the pooled trust is to forfeit the income overage to the Medicaid agency, okay, so that you can get below that $845 threshold. Okay, so the income component is confusing, and it's very fact sensitive. In the world, the next category is penalties. In the world of community Medicaid, gratefully in New York State, there are no penalties. Okay, so if somebody was to transfer money to make themselves eligible for Medicaid, for example, if they have $100,000 in their name with their home and they want community Medicaid, they can transfer that the overage of the money, let's say $90,000 to bring them down to 10, to a child, and they can transfer the home subject to a lot of rules about taxes and the facts, perhaps to a child as well, or even to an irrevocable trust. And Medicaid for the community will not penalize those asset protection steps. Okay? If we're talking about nursing home Medicaid, then we have a problem. So nursing home Medicaid has significant penalties. However, community Medicaid does not. So we can undertake our asset protection steps. However, we must be mindful and keep the money and the assets nearby should the applicant parent ever need a nursing home within 5 years. So you can undertake that transfer to a child, okay, but if that child goes and spends the money, and then if mom needs to go into a nursing home in 2 years, that is within the nursing home 5-year look back, and we will then have some penalties and some problems. And that only disappears if the child can give the money back to the parent. So all community Medicaid eligibility planning has to be done with a view towards the possibility that nursing home Medicaid may be necessary. But a straightforward community Medicaid application, there are no penalties for transfers and asset protection. Now, the look-back period, the next point. The look-back period itself, this 5-year look-back that you hear about, that is only for nursing homes. The community Medicaid program only has a 3-month look-back. Okay, some attorneys don't even call it a look-back period, but it is a 3-month look-back in which Medicaid looks back at all the assets and the accounts. But it's really just a period of time in which they can see the assets and where they are and where they've gone. But again, if a person has $100,000 in their name in June and they're looking for community Medicaid in July, they can transfer that $100,000 or less then out of their name and apply for Medicaid in the community for July, subject, of course, to all the rules and regulations. And then when you provide the 3-month look back of financial records, they'll see the transfer. They'll see the June balance of $100,000, and then they'll see the July balance of $10,000. It's only a look-back period to see what's going on with the finances. So they will not calculate any penalties if they find transactions and gifts. It's the opposite with the nursing home Medicaid. They go back 5 years, and they will penalize, and they will deal with those, and you'll have some issues with that. So again, 3 months only for community Medicaid. The next topic is documentation. Documentation is basically all that is needed to complete the Medicaid application. It is, unfortunately, the number one reason that we get denials. If an application is denied, more often than not, it is because the family was unable to explain something or provide something document-wise. A good law firm that does this type of work consistently should really have all the documentation in place before the application is filed, and that firm should have audited all of the statements and all the transactions and know exactly what's going on before it's even submitted, so you can address those issues within the application itself and avoid the back and forth with the Medicaid agency, or even avoid a denial forcing an appeal. So the documentation is crucial. There's 2 main parts to the documentation. The first is the biographical, and then the second is the financial. We've already discussed the financial part. Biographical would be, picture ID, such as a driver's license or passport, birth certificate, marriage certificate, spousal death certificate, deed to the house or a lease to the apartment. health insurance cards, and the like, veterans forms, but that's documentation, Medicare card, etc. Okay. Once the Medicaid agency receives the application, okay, there will often be a couple of weeks in which the Medicaid will review it, and then they'll send out what's called a penned letter. Okay, a penned letter is where they say this is what's outstanding, this is what's pending, and then we'll have about 10 days to get whatever's missing from the family and then supply it to the Medicaid agency. Very honestly, we warn and advise clients and very seriously about these issues. It's not good to file an application knowing you're missing something unless you know it's on the way, and it's not good to file to avoid or ignore to ignore a penned request, because then you'll receive a denial, which means you're not going to be able to get services in the house. In the home care world, the services are less expensive than nursing home, so if you have to refile an application or delay the processing of the application because the family is still gathering information, it's expensive, but it costs less than nursing home. Okay? The timeline typically for a Medicaid application is about 4 to 5 months. Sometimes they've taken longer, sometimes they've taken less. It generally takes the family a month to get all the documentation. Again, it could be a little less, it could be a little longer. It then generally takes the Medicaid agency 2 to 3 months to make their initial determination as far as the legal and financial application. And then the last month is typically the health assessments. And that last month, and these health assessments are new. It's really only began within the last year. And there are, in this home care community Medicaid application, 2 health assessments. So once the legal and financial application is approved, then the first health assessment occurs. That first health assessment is what's called a conflict-free assessment. And that's where New York State sends in an intermediary to spend about 2 hours with the applicant, going through an assessment, asking questions to determine whether or not the applicant will require these long-term care services in the community for at least 120 days. If you recall, I mentioned that 120 days in the beginning. That's that same 120 days. And most clients meet that threshold, which then leads to the second assessment, which is what's called the MLTC assessment. And that is the actual managed long-term care company sending in a nurse, again, unfortunately, for about a 2-hour assessment to literally determine what tasks are that need help and determine what type of hours are required. So it's that second assessment from the MLTC company where the hours are determined. The assessments are crucial. A firm like ours, depending on the services we're involved with, will actually send an advocate to the house to deal with these issues with the family. And that's that life care planning service that Kate mentioned earlier. Those assessments are crucial, and they need to be dealt with prudently and reasonably and honestly, but they have to be taken very seriously, because that's how you determine the hours, which equates to the dollars and cents of the care. Now, the risks. So the last topic in regard for my talk today. Whenever you're looking at Medicaid, it will make sense financially to do it, and it is good care. However, there are some risks. In essence, you are getting the state, the government, to pay for the care. Home care can be, again, anywhere, $2,000 to $8,000 or $9,000 a month. Nursing home care can be anywhere from $14,000 to $20,000 a month. So there are some risks associated with Medicaid. Gratefully, the risks are small, but they are risks and they can happen. For example, I mentioned earlier, if there is an asset left in the Medicaid applicant, or at this point what we call the recipient's name, and if it's in their name solely and they pass away, then there is something called estate recovery, where Medicaid can, in fact, recover from those assets before they get transferred to the beneficiaries. So it's always important to avoid having the recipient have what's called an estate, and you avoid that by either having assets in a trust or having assets jointly owned with somebody else. Other risks, for example, if we have a spousal situation, and if the spouse passes away before the Medicaid recipient does, whether home care or nursing home care, the spouse will often have a last will and testament or trust that leaves the assets to the family versus the Medicaid recipient. That's a prudent way to address the planning for what we call the community spouse. And that type of planning will have assets bypass or disinherit the Medicaid recipient. Well, Medicaid has a right to stand in the shoes of the Medicaid recipient and actually say, you can't disinherit me. I want to elect against my deceased spouse's estate. It can happen. It doesn't happen all the time, doesn't happen every time, but it is a risk, and it means that a percentage, up to a third, perhaps even half of that, can be susceptible to Medicaid collection. Another example of a risk is Medicaid asking a spouse who has refused to pay for the care, and let me explain that for a moment. When a spouse has assets, a community spouse, the one not applying for Medicaid, has assets that exceed the guidelines that on the law that Medicaid says, then that spouse is going to sign what's called a type of application that's called a spousal refusal application, where the one spouse is saying, I can't afford to pay for my other spouse's care. It's just too costly. And when that type of a form is filed, then Medicaid has the right to ask the community spouse to contribute and pay back the money. Again, it doesn't happen all the time, but it is a risk. The bottom line when you're looking at Medicaid eligibility and the benefits and the risks is that Medicaid can only pursue that which they've paid out. And they always pay for the care less than we as consumers do. The best example is a nursing home scenario. If somebody goes into a nursing home and they're paying $16,000 a month for that nursing home, and they're there for 10 months, that's $160,000 out of pocket, period. However, if they do undergo the Medicaid application process and receive Medicaid benefits, and if there's a claim by Medicaid, they're only able to pursue not the 16 because Medicaid doesn't pay that $16,000 number. They can only pursue which they've paid out, which is going to be a contracted amount, roughly, let's say 60%. It fluctuates, and minus whatever income was contributed by the Medicaid recipient. So if it's a $16,000 private pay bill, Medicaid may only be paying $7,000 a month, $6,000 a month for that care. So after the same 10 months at $6,000 a month, it's $60,000 versus $160,000. So financially speaking, the risks are worth taking, A, because the care is worthwhile, and B, because you'll be able to save some assets for the spouse and for the family and for the recipient as well. All right. So that, in a nutshell, is all you need to know when it comes to community Medicaid. Of course, it's important to meet with somebody, an experienced elder law attorney that does this type of stuff every day. There are certified elder law attorneys, as Kate had mentioned, and then there are those that are not certified, but they're just very experienced. You want to deal with somebody who's experienced because Medicaid is a difficult process. Okay, but thank you very much, and please, if there's any questions, I'll be happy to try to answer them.
Again, if you'd like to ask a question, please press star then 1 on your telephone keypad. Again, star 1 if there are any questions. And I'm showing no questions on the line.
Very good. Thank you again for everybody. Thank you.
Ladies and gentlemen, this concludes today's conference call. You may now disconnect.